Hi, my name is Joseph McHale. This is delayed diagnosis in ulcerative colitis leading to toxic megacolon. So in this case, a 17-year-old male presented with 3 days of vomiting after 18 months of intermittent abdominal pain and bloody stools. He was originally worked up 16 months before at an outside hospital where he received a colonoscopy with indeterminate pathology on results and was sent home for outpatient follow-up. At this point, he was lost to follow-up due to the COVID pandemic and never started any kind of medication. He was readmitted to our hospital as service with GI consult and planned for eventual colonoscopy after infectious rule-out. Initial CT showed inflammation from the ileocecal valve to the sigmoid colon with labs significant for anemia and inflammation with ESR up to 99. He was placed on bowel arrest with plan for serial exams and abdominal x-rays. Infectious workup was negative, but scope was delayed due to worsening on his x-rays. On day 6 of admission, patient developed worsening hematochezia, tachycardia, and worsening abdominal pain concerning for toxic megacolon. Repeat imaging and labs showed toxic megacolon with air in the bowel wall and dilation, with concern for DIC, sepsis, and electrolyte abnormalities on his labs. He was upgraded to the PICU, underwent subtotal colectomy with ileostomy, and repeat pathology of the surgical specimen confirmed diagnosis of ulcerative colitis. UC is a disease characterized by inflammation of the colon, which often occurs in a relapsing, remitting pattern. It's often controlled on medications in the setting of a timely diagnosis by biopsy, although some severe cases will still require colectomy. Treatment is never advised without a definitive diagnosis, as it can lead to inadequate treatment, incorrect treatment, or even worse, immunosuppression in the setting of underlying infectious process. In this case, he would have been considered severe by True-Love and Witts criteria based on his outpatient symptoms. For a patient with an established diagnosis, treatment would have been IV steroids and monitoring. If this failed after 3 to 5 days, you can decide on either IV cyclosporine or infliximab, or possibly colectomy, per ACG guidelines. It is notable that many people with severe presentations are actually prone to medical treatment failure. Some studies have shown rates up to 20 to 40% in severe colitis. And in one study with people with severe colitis treated with cyclosporine, 83% avoided colectomy at that time, but over half of those remaining required colectomy in the next 5 years. In patients with a clinical picture indicative of severe IBD that lack diagnosis required for treatment, it could be argued that an earlier colectomy could improve surgical outcomes and outcomes for the patient. Indications for surgery normally include perforation, hemorrhage, or failure of therapy. Little to no data exists comparing medical and surgical treatment. Delayed diagnosis of UC can lead to complications such as superinfection, toxic megacolon like this case, or thromboembolism. For many patients in this last year or two, the COVID pandemic has caused significant delays in care, with 41% of adults reporting delays in care and 12% reporting delays for emergent care. In addition, shutdown of outpatient procedures such as colonoscopies can have significant effects on the health of individuals. In this case, we can see the risks of avoiding necessary outpatient follow-up and how severe they can be.